We're starting with the important topic, that is anemia. So when we define about anemia, anemia is defined as a decrease in the RBC mass or decrease in the hemoglobin concentration below the normal range for the patient's age, sex, and altitude of residence. Now, when we talk about the hemoglobin levels, the normal hemoglobin levels in males is 13 to 17. In case of females, it is 20 to 16 grams per dl. In pregnancy, we say it to be anemia when it is less than 11, and in case of CKD, chronic kidney disease patients, it is less than 10. Now, corrected retic count. Corrected retic count is the retic count multiplied by the patient's hemoglobin divided by the desired hemoglobin. Normal corrected retic count ratio should be 0.5 to 1.5% is the range. Reticulocyte proliferation index is CRCY 2. If it is less than 2.5, then that means it's a hyperproliferative anemia. If it is more than 2.5, then that is hyperproliferative anemia. Now, classification of the anemia. The first is the morphological classification. In that, the first is the normocytic normochromic anemia. This happens in case of acute blood loss or hemolytic anemia or aplastic anemia. Then microcytic hypochromic anemia, the mnemonic is CETA, so it stands for sideroblastic anemia and deficiency anemia, thalassemia, and anemia of chronic disease. Macrocytic anemia happens in megaloblastic and non-megaloblastic anemia. So the megaloblastic anemia that consists of vitamin B12 deficiency, folate deficiency, and non-megaloblastic anemia that consists of the liver disease, hypothyroidism, or alcoholism. Now, next is the etiological classification. The blood loss, acute blood loss, it leads to normocytic normochromic anemia, and chronic blood loss leads to microcytic hypochromic anemia, wherein examples of chronic blood loss will be chronic GI hemorrhage because of colon cancer, peptic ulcer, or gynecological cancers like menorrhagia. Then the next is impaired red cell production. There can be disturbed DNA synthesis, megaloblastic anemia, then defective hemoglobin synthesis, leading to iron deficiency anemia, thalassemia. Then marrow infiltration, as in case of aplastic anemia, leukemia, myelodysplastic syndrome. Then stem cell disorders, aplastic anemia, and pure red cell aplasia. And the stem cell, and then the endocrine disorders like renal failure leading to erythropoietin deficiency and AOCD. Now, increased RBC destruction, that is hemolytic anemia, it can be intrinsic or extrinsic. So intrinsic, that is intracorpuscular defect. The first is hereditary causes. They include the membrane defects like the hereditary spherocytosis or hereditary elliptocytosis, enzyme deficiencies, G6PD deficiency, and pyruvate kinase deficiency. Then in the hemoglobinopathies, the sickle cell disease and thalassemia. Acquired one is going to be paroxysmal nocturnal hemoglobinuria. Now, extracorpuscular defects, here they include the immune mediated, that is autoimmune mediated hemolytic anemia, that is IHA, then drug induced or the SLE. Then in case of infections, malaria, Clostridium villi. Then in mechanical trauma, it is microangiopathic hemolytic anemia, DICT-TB. Right. Now, talking about the individual anemias, so first is the iron deficiency anemia. Now, very important, the RDA for males in iron is about 1 milligram per day. For females, it is 2 milligram per day, and in pregnant females, it is 3 milligram per day. 10% of all the iron that we consume is absorbed, and 0.5 milligram in case of children. Now, out of which 2/3 is stored in the 2/3 is bound hemoglobin, and 1/3 is stored inside our body. Now, there are two types of iron, heme iron and non-heme iron. Heme iron is something that we get from animal sources. Non-heme iron is we obtain from plant sources, and the iron that we obtain from the plant sources is Fe3+. It is converted into Fe2+ with the help of cytochrome B reductase. Now, there are certain agents that slow the absorption, that is the phytates, tannates, milk, and iron absorption pathway should be understood. So, iron is maximally absorbed from the duodenum. It is converted into from Fe2+ to Fe3+ form by haptoglobulin and ceruloplasmin. This ferroportin channel, the one that will shift it from the duodenum or the intestinal cells into the bloodstream, it is under the control of hepcidin. Now, there are stages of iron deficiency anemia. The stage 1 is a negative iron balance. The stage 2 is a compromised iron production, that is iron deficiency erythropoiesis, and class 3 is the proper iron deficiency anemia. Now, thus, the iron deficiency anemia is a hyperproliferative condition. The causes are chronic blood loss, as we already discussed. Then there can be decreased intake because of poor nutrition, malabsorption, as in case of celiac disease, Whipple's disease, atrophic gastritis, increased demand in pregnancy, in lactation, and in children. Now, clinical features, there will be general symptoms like fatigue, pallor, and exertional dyspnea. Apart from that, there are koilonychia, that is spoon-shaped nails, then glossitis, that is smooth red tongue, angular cheilitis. Then there will be pica, that is craving for ice, which is most common, that is pagophagia. Apart from that, clay starch, restless leg syndrome, and Plummer-Vinson syndrome. Plummer-Vinson syndrome consists of a triad of iron deficiency, anemia, and the post-recoid waves that will lead to dysphagia and glossitis. It is also called as Patterson-Gillibrand syndrome or centrobasic dysphagia. Then the next diagnosis is made by CBC only. We get to know about the iron studies as well. The serum ferritin level decreases, serum iron level decreases, total iron binding capacity increases, then transferrin saturation also decreases. On the peripheral smear also you can make it out. However, the gold standard is the bone marrow aspirate. There is a decreased staining after the Prussian blue stain or the pearl stain, but however it is rarely done. Then treatment is by oral iron therapy, parenteral iron therapy, or addressing the underlying cause. So oral iron therapy, it consists of ferrous sulfate, 200 mg TDS for 4 to 6 months, and parenteral iron therapy, iron sucrose, which is given thrice weekly, or ferric carboxyl maltose. Now the formula is called as Ganzoni's formula. It is 2.4 into body weight in kg plus 1000 or plus 500 microgram to replenish the stores. Then the next is megaloblastic anemia. So in the megaloblastic anemia, there is a deficiency of vitamin B12, and that will lead to impaired DNA synthesis. So the causes of vitamin B12 deficiency, that is megaloblastic changes, will be pernicious anemia, right, which is autoimmune disorder. Then gastrectomy, ileal resection. In Crohn's disease, the ileum is affected, or strict vegetarian diet, and bacterial overgrowth syndrome, that is blind loop syndrome. Similarly, the folate acid, which is maximally absorbed in jejunum, its deficiency is because of poor intake, or alcoholism, malnutrition, then malabsorption in celiac disease, and increased demand in pregnancy, lactation, and due to some drugs, antifolate drugs like methotrexate, phenytoin, cytarabine, or due to D-latem infection, that is Diphyllobothrium latem infection. So these are all these causes will lead to vitamin B12 deficiency and vitamin B9 deficiency. They will lead to megaloblastic changes. Now, very important are those factors will lead to normoblastic changes, but DNA synthesis is impaired. So these are myelodysplastic syndrome, then amino aciduria, liver disease, alcoholism, hypothyroidism, and scurvy. So you can remember this by mnemonic SHAM: scurvy, hypothyroidism, alcoholism, AA, that is amino aciduria, and M stands for myelodysplastic syndrome. Now, the vitamin B12 absorption pathway is very important, how it is ingested and what all things bind to it and how it is absorbed. So it is absorbed by cubilin receptor, and there is a cubilin receptor defect which is congenital, that is called as Imerslund-Grasbeck syndrome. Clinical features against the general anemia symptoms will be present. Glossitis, that is beefy red tongue, will be present. Mild jaundice-like features can be seen due to unconjugated hyperbilirubinemia. Neurological symptoms, they are common only in vitamin B12 deficiency. So that includes the peripheral neuropathy, subacute combined degeneration of the spinal cord, and the cognitive changes. Folate deficiency, however, does not present with any neurological symptoms. Now, but however, if there is a deficiency of vitamin B12, that leads to certain thing called as folate trap. Diagnosis again by CBC peripheral smear will show macrovalocytes, anisopoikilocytosis, hypersegmented neutrophils, Cabot rings, Howell-Jolly bodies. Right, hypersegmented neutrophils is the earliest sign. Bone marrow studies are considered to be the gold standard. Then biochemical test, serum B12 levels have been decreased, serum folate level decreases, and homocysteine levels increase. Methylmalonic acid levels, they are going to increase. So we do a serological testing for anti-intrinsic factor antibodies and anti-parietal cell antibodies. This is also associated with Addison's disease, type 1 diabetes, vitiligo, increased risk for cancer, and gastric carcinoma type 1. Vitamin B12 deficiency, that management is 1 milligram iron injection of hydroxycobalamin. 6 doses are to be given over 2 weeks, and then maintenance dose for every 3 months. One same dose once a month is given. Oral vitamin B12 can be given if the absorption is intact. Folate deficiency, oral folic acid tablets 4 to 5 milligrams per day for daily 3 to 4 months can be taken. Is one concept called as IRIDA, that is iron resistant iron deficiency anemia. This is because of the increased levels of hepcidin. It's a congenital condition where there is a inherited iron deficiency anemia. Then the two short conditions, that is anemia, chronic disease. Anemia, chronic disease is because of certain chronic diseases. So this hepcidin is the one that is going to inhibit the ferroportin. Now this hepcidin is uh, inhibited because of hypoxia, and thus the iron increases in circulation. But if there is a chronic disease like hemochromatosis, HFE gene mutation, or hemojuvelin, then it will activate this hepcidin that will in turn inhibit ferroportin, and because of which the iron circulation will decrease. HFE, it prevents the iron overload and it is required in our body as well, but it is disproportionately high in case of hemochromatosis. Similarly, in infection, in chronic conditions, the CRP levels increases and they are going to activate this hepcidin, because of which the circulating iron levels decrease, but however the serum ferritin levels are increased or normal. Then sideroblastic, and because of which the total iron making capacity is low. Serum, then sideroblastic anemia. Sideroblastic anemia, it is inherited condition. This is because of the ALA synthase defect, and because of which the protoporphyrin rings around in the hemoglobin, they are not synthesized. The iron is present, it accumulates around the hemoglobin like a ring, and because of which the ring sideroblasts they are seen on fusion staining. Acquired causes, it can be myelodysplastic syndrome or copper deficiency. There is increased serum iron levels, and total iron binding capacity over here is also low. Then moving on to the next type, that is called as thalassemia. Thalassemia is a hereditary condition which is characterized by reduced or absent synthesis of one or more globin chains in the hemoglobin. So the classification of thalassemia is of two types. There is alpha thalassemia, similarly there is a beta thalassemia. Alpha thalassemia is due to the deletion or mutation of the alpha globin chains. These alpha globin chains are located on chromosome number 16, and there are a total of 4 chains. So if one chain is absent, it's called as silent carrier. If two chains are absent, then that is called as alpha thalassemia trait, where mild anemia is seen. If three chains are absent, then that will lead to hemoglobin H disease, and here the Gulf ball inclusions are seen. It will lead to moderate anemia, and if all the 4 hemoglobin chains are absent, then that will lead to hydrops fetalis. That is it is fatal in utero only. The child will die inside the uterus itself. That is called as HP Bart's disease. Then beta thalassemia. It is due to the mutation in beta chain, and this beta chain gene is located on chromosome 11. There are total of two beta chains. So if one beta chain is absent or it is not working, then that will lead to beta thalassemia minor. It's a asymptomatic carrier. Then beta thalassemia intermedia. Here the HbA2 levels, hemoglobin F levels are going to increase. And beta thalassemia major, where both of the chains are not present. Then these are the transfusion dependent thalassemia. And in transfusion dependent thalassemia, there is HbA levels, they are very less, that is less than even 3%. And normally the HbA2 levels, which should be less than 3.5%, here they have been increased. Similarly, hemoglobin F levels, it increases up to 90%. The genetics and pathogenesis is autosomal recessive condition. It is caused because of imbalanced alpha is to beta globin chain ratio. Alpha thalassemia, here in alpha thalassemia there are excessive beta chains leading to HbH disease or hemoglobin Bart's disease, while in beta thalassemia there are excessive alpha chains, and that will lead to ineffective erythropoiesis. The compensatory mechanisms in beta thalassemia will be increase in levels of fetal hemoglobin, that is alpha to gamma 2, and increase in levels of HbA2, that is alpha to delta 2. Now talking about the clinical features of beta thalassemia major, that is also called as the Cooley's anemia. So it presents at around 6 to 24 months, because at 6 months the fetal hemoglobin levels start to decline. It presents with severe anemia, pallor, failure to thrive, and fatigue. Extramedullary hematopoiesis. In extramedullary hematopoiesis, hematosplenome, that leads to hepatosplenomegaly. Then bone deformities. Thalassemic facies happen, that is frontal bossing, and a maxillary hyperplasia, that is called a chipmunk facies, and hair on end appearance on the skull X-ray. Similarly, it leads to growth retardation, and complications of transfusion will lead to iron overload. So the iron overload that can lead to restrictive cardiomyopathy, liver cirrhosis, or endocrine failure. Beta thalassemia intermediate and minor, they come with mild to moderate anemia, and they are treated by either oral iron or by IV parenteral iron. In alpha thalassemia, if it's HbH disease, then it comes with moderate hemolytic anemia, jaundice, and splenomegaly. And in hydrops there is a stillbirth or death in utero itself. Then the diagnosis, it is by CBC. We come to know it's a microcytic hypochromic anemia. Peripheral smear show target cells or godocytes. Basophilic stippling is seen, and very important in thalassemia, there is nucleated RBCs that are seen. Then in alpha thalassemia, there is hemoglobin H inclusions, that is supravital staining. Then in Mendel's index is more than 13 in deficiency anemia, it is less than 13 in thalassemia. Then hemoglobin electrophoresis in the beta thalassemia measure will find increased hemoglobin F and hemoglobin A2 levels are more than 3.5%. In beta thalassemia minor or trade, the fetal hemoglobin won't be 90%, it will be 1 to 5% only, while the hemoglobin A2 levels will surely increase. Then molecular genetic testing is required for confirmatory diagnosis. As compared to iron deficiency anemia, in iron deficiency anemia, the RDW, red cell distribution, where it is high, but in thalassemia, it is going to be normal. Now, beta thalassemia measure. So, in the beta thalassemia measure, the management is going to be regular blood transfusion. You have to maintain the hemoglobin of the patient to be more than about 9 to 10 grams per DL. But however, hypertransfusion should not be performed, that is, it should be less than 12 grams per DL. Then iron chelation therapy can be given by deferoxam, interferoxerox, or deferiprone if in case the serum ferritin goes above 1000 micrograms per liter. Splenectomy is indicated if there is hypersplenism and post-splenectomy prophylaxis by the vaccines pneumococcal, meningococcal, and HIV. Folic acid supplementation, allogenic stem cell transplantation, and supportive care are also provided. Then beta thalassemia intermedia, the transfusion should are given as needed, and hydroxyurea, it increases the hemoglobin F levels. Then alpha thalassemia or HbH, hemoglobin H disease, avoid oxidant drugs like in G6PD deficiency and splenectomy. Complications such as acid ion overload, infection, osteoporosis, growth failure, and increase the chances of thromboembolism. Next is the sickle cell anemia. So in the sickle cell anemia, that is caused, it's autosomal recessive hemoglobinopathy, and it is because of the substitution of the valine for glutamic acid in the sixth position of hemoglobin chain, that is HbA to SPS. Hemoglobin S, it polymerizes under the low oxygen tension, and because of which RBC sickling happens, and that will lead to vasocclusion and hemolysis. The clinical features are it leads to chronic hemolytic anemia, again the same thing, that is pallor, jaundice, gallstones, and growth retardation. Similarly, very important thing, it leads to vaso-occlusive crisis, that is acute severe pain in the bones and in the chest region, that is called as acute chest syndrome, and abdomen, joints, and infections due to functional asplenia in these patients. The infection of the encapsulated organisms increases. Then organ complications in CNS, it leads to stroke and seizures. In case of renal system, it leads to papillary necrosis. Eyes, it leads to retinopathy, blindness. In the bones, it leads to avascular necrosis of the femoral head, as well as osteomyelitis. Then squaring of the small digits happen, and skin, it leads to chronic leg ulcers, and cardiac complications will be cardiomegaly. Then the diagnosis, again, it is made by CBC, where there will be anemia, peripheral smears. It will show sickling of the cells, target cells, and Howell-Jolly bodies. Now there is something called a sickling test. A sickling test, we use a compound, a chemical compound, that is called as sodium metabisulfite. Sodium metabisulfite, it creates a low oxygen tension, and because of which these RBCs are going to polymerize and will lead to sickling. Hemoglobin electrophoresis, no hemoglobin A, more than 80% hemoglobin S levels are seen, and prenatal diagnosis can be done by chorionic villus sampling or amniocentesis. Management, we give hydroxyurea. Hydroxyurea increases the fetal hemoglobin levels and reduces the frequency of crisis. Supportive care can be pain management or hydration, oxygenation. Then transfusion, there can be simple or exchange transfusion, and the prevention of sickle cell anemia can be by penicillin prophylaxis, then vaccinations, and folic acid supplementation. This prevents the infections. And curative, however, the only method is allogenic stem cell transplantation. Then the next is the hereditary spherocytosis. So in the hereditary spherocytosis, that it is an autosomal dominant as well as autosomal recessive condition, but mainly it's autosomal dominant condition because of the ankyrin mutation. In spectrin mutation, it is going to be autosomal recessive in nature. It is because of defect in the RBC membrane proteins. The result, because of the loss of RBC membrane surface area, all these RBCs, which are normally biconcave in shape, they turn into spherical shape, that is spherocytes, and that will lead to sequestration inside the spleen, that is splenic sequestration and destruction. Clinical features, there will be of variable severity. Asymptomatic to severe hemolysis will happen. Chronic hemolysis, that will end up in intermittent jaundice, anemia, splenomegaly. Then it can lead to crisis, that is aplastic crisis because of parvovirus B19 infection. There is a transient arrest of the erythropoiesis, hemolytic crisis because of increased hemolysis, infection or stress, megaloblastic crisis because of folate deficiency. Complications, it will again lead to pallor, jaundice, pigment gallstones, and leg ulcers, growth retardation in case of children. Diagnosis again made by CBC, peripheral smear where it will show the spherocytes, and there will be small dents, and there will be lack of central pallor. Osmotic fragility test, the fragility will be increased. Then the diagnostic can be eosinophil 5-alamide test, which is a flow cytometry. But however, the gold standard is STS page electrophoresis greater than ectocytometry. Direct Coombs test will be negative, and glycerol lysis test or pink test will be positive. Treatment for splenectomy, there is an elective for hereditary spherocytosis. There is an elective splenectomy that is done at around 6 years of age to avoid the infection risk. Pre-splenectomy vaccinations are given, lifelong penicillin prophylaxis is given, and supportive is folic acid supplementation and cholecystectomy if the gallstones are symptomatic. The management of the crisis can be done by transfusion of folate or by treating the infection simply. Then the next is going to be the G6PD deficiency. So glucose 6-phosphate deficiency is an X-linked recessive disorder. This is a XLR, and it is characterized by reduced activity of the glucose 6-phosphate dehydrogenase enzyme, which is required for increasing the levels of glutathione inside the body, and because of which what happens is the RBCs, they are prone to oxidative stress and hemolysis. Now it is common in Mediterranean areas, African or Middle Eastern areas. One of the commonest enzyme deficiencies worldwide. Males are generally commonly affected. The enzymes that are involved, that is the G6PD, glucose 6-phosphate dehydrogenase enzyme. It is seen in case of HMP pathway or pentose phosphate shunt pathway. It generates the NADPH, which maintains the glutathione in the reduced form, and it protects the RBC from the oxidative damage. Oxidative stress will lead to denaturation of hemoglobin. Formation of Heinz bodies will take place. Splenic macrophages, they remove the denatured hemoglobin, and because of which this particular part is bite of that is called as the bite cells, and this will eventually lead to intravascular and extravascular hemolysis. Now, precipitating factors will be some drugs like primaquine, nitrofurantoin, sulfonamides, or dapsone. Infections will be the most common trigger. Favapines or favism and severe metabolic stress. Clinical features, the patients are usually asymptomatic, but however, upon the stress factors, they will lead to hemolytic anemia. Then sudden pallor, jaundice, dark colored urine because of hemoglobinuria. Investigations on the peripheral sphere will find the bite cells, and blister cells can be seen. Upon supravitreal staining, the Heinz bodies can be visualized, and there will decrease hemoglobin, increase reticulocyte count. The confirmatory investigation is the G6PD enzyme assay. Fluorescence spot test can be used for screening. Management is here to avoid the precipitating factors like the drugs and foods, treat the underlying infection, and blood transfusion if it's a case of severe anemia. Then the next is the autoimmune hemolytic anemia. Autoimmune hemolytic anemia is an acquired hemolytic disorder, and it leads to premature destruction of the RBCs. It is going to be a type of hemolytic anemia, and because of which the reticulocyte proliferation index will be more than 2.5. It is hyperproliferative anemia, and this leads to intravascular and extravascular hemolysis. The classification of autoimmune hemolytic anemia is warm IHA and cold IHA. So warm autoimmune hemolytic anemia, the antibody type is the IgG. Then the agglutination, it happens at 37 degrees Celsius. The mechanism is this IgG coated RBCs, they are destroyed by the splenic macrophages, and that will lead to extravascular hemolysis. Causes are idiopathic, and in secondary the causes are SLE, CLL, and drugs like methyl dopa and penicillamines. Cold antibody IHA, in that there are two diseases, cold agglutinin disease and the paroxysmal cold hemoglobinuria. So generally the cold agglutinin disease, the antibody type is IgM, and the temperature is 4 degrees Celsius. Mechanism is that this IgM fixes the complement protein, and because of which intravascular hemolysis or extravascular in liver happens. Now the cold agglutinin disease will lead to chronic idiopathic or secondary infections. Paroxysmal cold hemoglobinuria leads to intravascular hemolysis, while warm IR and the cold agglutinin disease, they are cases of extravascular hemolysis. In IgG antibody, that is known as landstinol antibody, is present. It is generally seen post-viral in case of children. Then the antigen is the polyclonal antigen, the P antigen, known as landstinol antibody is polyclonal. Now, based on the direct Coombs test will be positive. Now, based on the etiology, there can be primary idiopathic or secondary. It is autoimmune disorders associated with say rheumatoid arthritis or infections like mycoplasma seen in cold IHA. Then lymphoproliferative disorders like CLL, lymphoma, Waldenström's microgammaglobulin it is seen in case of cold IHA. Then drugs like methyl dopa, penicillin, lenalidomide. Pathogenesis of the autoimmune hemolytic anemia is caused because of loss of self-tolerance and because of which the production of autoantibodies takes place. Opsonization of the RBCs because of the immunoglobulins like IgG or C3b, and complement activation it is caused because of immunoglobulin M. This immunoglobulin M is actually going to stop the complement proteins and because of fixes the complement and because of which intravascular hemolysis happens. Then drug-induced mechanisms will lead to immune complex formations. And clinical features, general hemolytic symptoms like fatigue, pallor, jaundice will be present apart from the dark urine because of hemoglobinuria. In case of intravascular hemolysis, that is paroxysmal cold hemoglobinuria. Specific features are warm IHA, it is insidious in onset, splenomegaly is seen. Cold IHA, it leads to acrocyanosis, and paroxysmal cold hemoglobinuria, it will lead to hemoglobinuria upon cold exposure. And diagnosis is made by CBC, peripheral smear, it will show spirocytes in case of warm IHA. Schistocytes of fragmented RBCs can also be seen. And RBC including a cold IHA, it will lead to the formation of sheets of cells. Then the hemolysis markers. The hemolysis markers, there will be increase in unconjugated bilirubin levels, increase in LDH levels, decrease in serum aptoglobulin levels, urobilinogen level increase, hemoglobinuria is seen in case of intravascular hemolysis. Direct Coombs test is positive. Warm IHA, IgG positive, C3 positive. In cold IHA, there is IgM positivity, but however, it is not detected on direct and antigen test. C3b activation, because of which C3 is positive. Then indirect Coombs test, it detects the free antibody in the serum. So indirect Coombs test is better as compared to direct Coombs test. Donut landstinol antibodies present in paroxysmal cold hemoglobinuria. Then the management. So management of warm IHA is the first line, we use steroids, prednisolone 1 mg per kg per day. Second line can be splenectomy if steroids fail, or other immunocompressants like the azathioprine cyclophosphamide. And third line will be anti-CD20, that is rituximab, or IVIG, IV immunoglobulins. In cold IHA, avoid the cold exposure. The first line is not the steroids in cold IHA, it is rituximab. Other immunosuppressants can be given or plasmapheresis can be done. In case of drug-induced, stop the offending drug. Folate supplementation or blood transfusion as and when required if it's a case of severe. Prognosis, warm IHA has a good response. However, cold IHA, it may be associated with lymphoma. And complications, severe anemia can lead to heart failure, and because of which blood transfusion can be done. Hemolytic crisis can happen, and thrombosis is Ivan syndrome, that is autoimmune hemolytic anemia plus ITP, immune thrombocytopenic purpura. Lastly, there is aplastic anemia. Aplastic anemia is characterized by severe bone failure, severe bone marrow failure, and is characterized by pancytopenia. So not only anemia but also WBC, neutropenia, thrombocytopenia is seen. Hypocellular bone marrow, and it is replaced by fat, and absence of leukemic or abnormal cells in the marrow or blood. Now classification is based on severity. If it is considered to be a severe aplastic anemia if the neutrophil count is less than 0.5 into 10 to the power 9, and if it is less than 0.2 into 10 to the power 9, then that is called as very severe aplastic anemia. However, the cellularity in both the conditions can be less than 25%. Based on the etiology, it can be inherited aplastic anemia. Inherited aplastic anemia is seen in Fanconi syndrome, Diamond-Blackfan anemia, and telomerase defects. Acquired, it is idiopathic most common and due to drugs or chemical or radiation. Then talking about the pathogenesis, it is idiopathic as I said. Then in case of drugs, it is dose dependent, and sometimes cytotoxic drugs like alkylating agents and antimetabolites or benzene. Idiosyncratic reaction is seen in penicillamine or NSAIDs. Then infections like viral hepatitis non-A, non-B. Then Epstein-Barr virus, cytomegalovirus. This can also lead to aplastic anemia. Then inherited conditions like Fanconi's anemia, which is autosomal recessive, caused because of chromosomal fragility. And apart from that, the diamond blackfan syndrome can lead to this. Pathogenesis, there is a stem cell injury or stem cell destruction leading to immune-mediated mechanism and T cell attack, microenvironment defect, and telomere dysfunction. Because of this, the RBCs they die. Now, the clinical features because of anemia, obviously there will be fatigue, pallor, dyspnea. Due to neutropenia, there will be recurrent infections, fever, sore throat, and thrombocytopenia will lead to bleeding, petechiae, then ecchymosis or epistaxis. Now, there will be no hepatomegaly or splenomegaly or lymphadenopathy in this particular case. Fanconi anemia features it is autosomal recessive in nature. There will be anomalies on the thumb or the radius, and renal malformations will be present. High risk of acute myeloid leukemia or myelodysplastic syndrome is present. And the diagnosis, laboratory diagnosis of the CBC will find myelocystopenia, reticulocytopenia. On peripheral smear, you will not found any abnormal cells. But on bone marrow aspiration, you'll find hypocellularity, more than 70% fat replacement, or you can say less than 30% cellularity is present. Iron stores, however, are increased. Then additional test is serum iron and transferrin saturation is increased. The flow cytometry is done to exclude paroxysmal nocturnal hemoglobinuria, that is CD55 or CD59 deficiency. And the differential diagnosis can be myelodysplastic syndrome, leukemic leukemia, or myelofibrosis. Management of this case, so management by supportive care before for transfusion, packed RBCs for symptomatic anemia, then platelets for bleeding or count less than 10 into 10 to the power 9. The infection management by broad spectrum antibiotics, antifungals, antivirals. Growth factors can be given, that is GCSF or GMCSF, to decrease the infection risk. Erythropoietin or thrombopoietin agonist, that is L-thrombopac, is given. Definitive therapy can be allogenic stem cell transplant, which is a curative treatment of choice. Apart from that, immunosuppressive therapy, that is IST, it is the first line for older patients. Then cyclosporine, prednisolone, and antithymocyte globulin can be given. Other agents are alemtuzumab, and for management of the refractory disease, we go for alternative donor transplant and sirolimus. Prognosis, it's an untreated condition, then the patient dies within 6 to 12 months. If hematopoietic stem cell transplant takes place, then 5-year survival rate is 80 to 90%. And in the complications will be infections will be the major cause of death, and bleeding, especially intracranial hemorrhage. Transfusion related complications, again the same: iron overload, alloimmunization, and graft versus host disease. Then Fanconi's anemia. Fanconi's anemia is an autosomal recessive condition, as I said, progressive pancytopenia. It is caused because of chromosomal fragility and congenital anomalies that is involving the radius and the thumb. There is a high risk of AML, MDS. Then diamond blackfan syndrome is a congenital pure red cell aplasia, and it is characterized by severe macrocytic anemia, reticulocytopenia, while the WBC and platelet counts over here are normal. There is increased risk of MDS and AML, just like Fanconi's anemia, and here it is characterized by short stature, craniofacial, and thumb defects. Now, in case of pyruvate kinase deficiency, there is a presence of echinocytes at the birth cells. Now, the next is intracorpuscular acquired defect, that is called as paroxysmal nocturnal hemoglobinuria. PNH is caused because of a defect in the PIGA gene, which is located on chromosome X, and that will lead to deficiency of GPI anchored proteins, that is CD55 and CD59. CD55 is called as decay accelerating factor, CD59 is called as membrane inhibitor of reactive lysis. Chronic complement mediated intravascular hemolysis takes place, and subsequent bone marrow failure. Then comes with the classical triad of hemolytic anemia, thrombosis, and different cytopenias. The thrombosis, venous thrombosis, is hepatic venous thrombosis, that will lead to Burchari syndrome, which is most common. Apart from that, cerebral venous thrombosis can be present, which is a leading cause of death. Then hemoglobinuria, that is a dark color urine that is seen in the morning. Why? Because during the night, the body goes into hypoventilation. There is a respiratory acidosis, and these complement systems are activated. But here now, CD50 or CD59, which is inhibiting this complement system. They are now not present, and because of which the RBCs will undergo lysis. Then symptoms, there will be abdominal pain, dysphagia, difficulty in then erectile dysfunction, then fatigue, renal impairment. Diagnosis made by flow cytometry, which is the gold standard, which will show deficiency of CD51 and CD59. Similarly, the neutrophils alkaline phosphatase levels will be decreased, and intravascular hemolysis markers, that is decreased serum haptoglobin, increased LDH, increased levels of urobilinogen can be seen. Historical tests that were done for this condition were the HAMS test and Screw's lysis test. Then the management for this condition is going to be the eculizumab, and eculizumab is a anti-C5 complement monoclonal antibody. Similarly, romuluzumab can be given, that reduces the chances of hemolysis, thrombosis. Supportive care can be transfusions, anticoagulants can be given, iron folic acid supplementation. Curative care only is the allogeneic stem cell transplant, and regular monitoring of LDH levels, CBC levels, renal function, and thrombosis screening should be performed. Then the next is the examples and the difference between the intravascular and extravascular hemolysis. So intravascular hemolysis, as the word suggests, it takes place inside the blood vessel, while extravascular hemolysis takes place outside the blood vessel. Intravascular hemolysis presents with hemoglobinemia, hemoglobinuria, hemosideриnuria, and serum haptoglobin levels are markedly decreased in this, while the lactate dehydrogenase levels are also markedly increased, and it will show cystocytes or helmet cells or fragmented RBCs on peripheral smear. In extravascular hemolysis, more commonly what is seen is the death of the RBCs in the reticular endothelial system of the spleen and the liver, because of which splenomegaly is common. Then hepatomegaly is common. Similarly, it will lead to spherocytes on the peripheral RBCs, and also there will be pigmented bile stones are seen. Now, the examples of these are, in intravascular hemolysis, the examples of microangiopathic hemolytic anemia, that is host TTP, and DIC HELP syndrome, then macroangiopathic hemolytic anemia, then malaria or toxins, that is snake bite, spider bite, and transfusion reactions. While in case and paroxysmal nocturnal hemoglobinuria. So paroxysmal nocturnal hemoglobinuria is an intracorpuscular defect. But generally, all the intracorpuscular defects this show extravascular hemolysis, but this is an exception. Extravascular hemolysis seen in, as I said, all the intracorpuscular defects, so membrane defects, autoimmune hemolytic anemia. So warm autoimmune hemolytic anemia and cold agglutinin disease, they show extravascular hemolysis. On the other hand, paroxysmal cold hemoglobinuria shows intravascular hemolysis. Hemoglobinopathies like sickle cell anemia, thalassemia, and enzyme defect is XPD deficiency, pyruvate kinase defect. So they show extravascular hemolysis. Similarly, atypical HUS, it also shows extravascular hemolysis.